Understanding peripheral neuropathy, mechanisms, causes, and evidence-based and quantitative approaches to improve nerve health. Number 1427, VMT Sharp 747, TDA Sharp 030, November 9, 2025. Gerald C. Shu, EclaireMD Foundation. Category: Neuropathy. Preface: Peripheral neuropathy is a common neurological condition, affecting millions of adults worldwide. It occurs when peripheral nerves become damaged or dysfunctional, leading to symptoms such as numbness, tingling, burning pain, reduced sensation, or loss of balance. Although neuropathy has many possible causes, the underlying mechanisms are often similar: impaired blood flow to nerves, metabolic injury, chronic inflammation, and structural degeneration of nerve fibers. Nerve fibers degeneration means that the structure and function of a peripheral nerve begin to break down over time. It is a biological process where parts of the nerve deteriorate, lose integrity, and eventually stop transmitting signals properly. This is one of the core mechanisms behind peripheral neuropathy. This article provides a clear, evidence-based and quantitative explanation of neuropathy, how it develops, why symptoms worsen with age or chronic disease, and what types of interventions may help improve nerve function. All information is drawn from established medical research and clinical guidelines. What peripheral neuropathy is: the peripheral nervous system connects the brain and spinal cord to the rest of the body. These nerves allow us to feel temperature, vibration, texture, position, and pain. They also control muscle contraction, reflexes, and automatic functions such as digestion and heart rate. When peripheral nerves are injured, signals become distorted or fail to transmit. This produces a range of symptoms: numbness or reduced sensation, tingling or burning, electric shock sensations, loss of balance or gait instability, difficulty walking steadily, muscle weakness, sensitivity to touch, difficulty feeling heat, cold, or pain. Neuropathy can affect one nerve, multiple nerves, or diffuse nerve networks. Major causes of neuropathy. Although neuropathy can occur for many reasons, the following are the most common causes. 1. Diabetes. Chronic high blood glucose damages small blood vessels that supply nerves. This reduces oxygen delivery, leading to nerve fiber degeneration. Diabetic neuropathy is the most common cause worldwide. 2. Vascular insufficiency. Conditions that impair blood flow, such as peripheral artery disease, hypertension, high cholesterol, or microvascular disease, reduce nutrient supply to nerves. 3. Metabolic or nutritional factors. Vitamin B12 deficiency, folate, vitamin B9 deficiency, and chronic alcohol use can injure nerves. Long-term renal or liver disease may also cause metabolic neuropathy. 4. Autoimmune conditions. Diseases such as lupus, rheumatoid arthritis, or inflammatory neuropathies, for example, SIDP, can damage peripheral nerves. 5. Toxins and medications. Certain chemotherapy drugs, heavy metals, and infections can damage nerve tissue. 6. Mechanical factors. Nerve compression from spinal stenosis, herniated discs, or chronic pressure on nerves can cause focal neuropathy. 7. Idiopathic causes, means the cause is unknown. In about 25% to 30% of cases, no clear cause is found, especially in older adults. Why nerves become more vulnerable with age. Scientific studies show that after age from 40 to 50, peripheral nerves gradually receive less blood flow due to natural vascular aging. Small arteries stiffen, capillaries narrow, and metabolic efficiency decreases. As a result, nerve tissue receives less oxygen. Regeneration slows. Sensory receptors become less sensitive. Healing after injury becomes limited. People with diabetes, hypertension, obesity, high triglycerides, or smoking history experience faster vascular decline and higher neuropathy risk. Understanding the core pathology. Nerve ischemia. One of the most important concepts in neuropathy is nerve ischemia, meaning insufficient blood supply to nerves. Nerves depend heavily on oxygen and glucose to maintain electrical signaling. Even mild reduction in blood flow can impair function. Maintaining healthy blood pressure and keeping MAP equal DBP plus, SBP, DBP, divided by 3, within the healthy range of from 70 to 100 mm of mercury is recommended. Researchers have shown that long-term nerve ischemia leads to loss of myelin, the protective sheath, a protective layer, around nerves, degeneration of axons, the long, thin extensions of nerve cells that carry electrical signals from the nerve cell body to other nerves, muscles, or organs, reduced signal conduction speed, poor sensory accuracy, reduced ability of nerves to regenerate. This mechanism explains why neuropathy often begins with numbness or tingling in the feet, where the longest and most fragile nerve fibers are located. How symptoms progress. Neuropathy typically follows a predictable pattern. Stage 1, sensory changes, mild tingling, burning, or decreased vibration sensation. Stage 2, reduced protective sensation, difficulty feeling heat, cold, or pain, greater risk of injury. Stage 3, balance and gait problems, loss of proprioception leads to unstable walking. Stage 4, weakness or muscle atrophy, the muscles shrink and become weaker, because they are not receiving enough nerve signals, or are not being used regularly. Advanced nerve damage impairs motor function. Stage 5, ulcers or infections, loss of pain sensation increases risk of unnoticed injuries, especially in diabetes. Note, in 2010, my foot ulcer almost required a toe amputation. Understanding the stage helps clinicians determine treatment priorities. Evidence-based approaches to improve neuropathy. There is no single cure for neuropathy, but many interventions can meaningfully improve symptoms or slow progression. The approach depends on the underlying cause. A. Improve metabolic and vascular health. For diabetes-related neuropathy, the strongest evidence supports stabilizing fasting plasma glucose, FPG, reducing hemoglobin A1C variability, improving insulin sensitivity, increasing daily walking, managing triglycerides and blood pressure, improved circulation reduces nerve ischemia and enhances healing capacity. B. Correct deficiencies. For neuropathy caused by nutritional deficiencies, treatment may include vitamin B12 replacement, folate, vitamin B9, supplementation, correction of thyroid conditions. These are essential for nerve metabolism and myelin synthesis. C. Physical activity and circulation-based therapies. Research shows that physical activity improves nerve blood flow and stimulates neuroplasticity. Examples include daily walking, balance training, low-impact aerobic exercise, light strength training. Exercise increases nitric oxide production, which widens blood vessels. D. Sensory re-education and nerve activation. Some rehabilitation methods aim to stimulate nerve pathways and improve sensation. These include vibration therapy, warm water therapy, gentle massage, tactile stimulation exercises. Clinical studies show these methods can enhance sensory accuracy in early and moderate neuropathy. E. Pain management, non-commercial. Medications and topical agents. Medications applied directly to the skin, rather than taken by mouth or injection, may help control pain. These do not fix the underlying cause but can improve quality of life. F. Addressing mechanical compression. For neuropathy caused by spinal or nerve compression, treatment may involve physical therapy, posture correction, stretching, in some cases, surgery if structural compression is severe, neuroplasticity and nerve regeneration potential. Although peripheral nerves regenerate slowly, the nervous system retains the ability to adapt. Neuroplasticity refers to the brain and nerves reorganizing themselves in response to repeated activation. Scientific findings show that improved blood flow enables axonal regeneration, the process by which damaged nerve axons grow back and reconnect with their target tissues. Repeated sensory stimulation can enhance nerve conduction. Consistent physical activity strengthens neural pathways. Even partial improvements in circulation and stimulation can lead to meaningful functional changes. What neuropathy treatment cannot promise. Reliable medical sources emphasize that long-term nerve damage does not reverse quickly. Severe neuropathy may not fully recover. No device or pill can repair nerves instantly. Regeneration takes months, not days. Note, for me, it took years. Realistic expectations are important for patients beginning any treatment. The most important principle, the single most important factor in neuropathy management, is addressing the root cause, treating only symptoms without improving circulation. Metabolic stability, nutrition, or nerve activation leads to temporary results. Long-term improvement requires consistent, daily attention to the underlying contributors. In my case, I chose the most fundamental approach to reduce my glucose level from over 300 mg per deciliter to about 120 mg per deciliter by eating less, eating correctly, and walking about 12,000 steps daily. My foot neuropathy gradually disappeared from 2011 to 2012, and has never returned. VMT analysis results. For this study, I selected a single output strain variable, the foot ulcer proxy, FUP, which integrates both glucose and weight-related loading on the peripheral nerves. It is defined as, this formulation reflects the dominant role of chronic hyperglycemia, while still capturing the influence of mechanical loading through body weight. When FUP exceeds 100, the patient will almost certainly develop neuropathy symptoms, at different levels of severity. When FUP falls below 80, neuropathy is usually under effective control. My FUP values and their corresponding cumulative VMT energy percentages demonstrate a clear pattern of improvement, with Y2017 serving as the turning point or the major inflection year. FUP score, VMT percent, 2010, 120, 0%, 2017, 100, 80%, 2022, 91, 87%, 2025, 89, 100%. The steady reduction in FUP from 120 down to 89 over 15 years indicates a continuous decline in peripheral nerve stress and cumulative metabolic injury. The VMT energy percentages quantify how much total damage has been mitigated over time, culminating in full stabilization by 2025. The VMT energy contribution ratios from each input stressor are: carbs and sugar is 38.4%, glucose, E/G, is 22.9%, walking steps is 20.0%, body weight is 18.7%. These detailed ratios illustrate that carbohydrate and sugar intake remain the dominant driver of neuropathic stress, followed by hyperglycemia. Walking steps demonstrate a strong protective effect by reducing daily strain, and body weight contributes a smaller but still meaningful share. These four detailed inputs can be grouped into broader domains. Diabetes-related factors is 61%, obesity-related factors is 39%, or alternatively, lifestyle inputs is 58%, biomarker-driven strain is 42%. These domain-level results confirm that both metabolic control and lifestyle management are essential for preventing progression of neuropathy, and for maintaining long-term nerve health. TDA analysis results. For the TDA study, I used the four stressors of glucose, N1, carbs and sugar intake, N2, weight, N3, and walking steps, N4. These four factors form a four-dimensional geometric shape over time. Principal component analysis, PCA, is applied to extract the dominant geometric directions from the shape, and to evaluate how the system contracts or stabilizes from Y2010 through Y2025. The first principal component, PC1, explains about 90% of the total geometric variation. All four stressors contribute almost equally to PC1, indicating that long-term system behavior is governed by the combined metabolic and lifestyle load, not by any single factor. PC1 therefore represents the main direction of overall stress contraction. PC2 explains around 7% of variation and captures the contrast between diet plus steps versus glucose plus weight. Changes along PC2 reflect how fast behavior improves relative to metabolic response. PC3 explains about 3% of variation, and represents small adjustments between diet and steps. The TDA trajectory in the 2D plane diagram of PC1 and PC2 shows a continuous path without any breaks. The early years, Y2010 to Y2014, occupy a widely spread region with large geometric distance, indicating unstable and high-stress conditions. After 2015, the shape begins to contract. By Y2019 to Y2025, the points form a tight and compact cluster, showing long-term stability across all four stressors. The 3D scatter diagram using PC1, PC2, and PC3 further confirms this contraction. Early years appear far apart, while mid and late years merge into a small geometric neighborhood. This indicates that lifestyle, diet, and metabolic conditions have reached a stable equilibrium. Radar chart diagrams of the early, mid, and late periods show the same trend. The early shape is large and dominated by extremely high carbs and sugar. The mid-period shows the strongest contraction due to major dietary reduction and improved glucose control. The late period is compact with only slight expansion driven by higher walking steps, which is a beneficial direction. A shape magnitude index confirms the same conclusion. The geometric magnitude decreases steadily from 2010 to 2025, with no reversals. The early period has the largest and most irregular shape. The mid-period shows the greatest contraction. The late period is stable and consistent with sustained low stress. Overall, TDA reveals three key findings. First, the system shows a strong and smooth contraction from high-risk to low-risk regions over 16 years. Second, all four stressors contribute almost equally to the dominant geometric direction, confirming that long-term improvement requires integrated management of diet, glucose, weight, and steps. Third, the final geometric cluster is compact and stable, matching the clinical improvement shown by the FUP strain reduction. The TDA geometry therefore validates that neuropathy risk reduction is not temporary, but structurally embedded in the long-term data pattern. Comparison between VMT and TDA. Key observation: the TDA findings are highly consistent with, and fully compatible with the VMT results. The VMT and TDA results complement each other, and describe the same long-term medical evolution from two different scientific viewpoints. VMT quantifies cumulative damage through energy accumulation, while TDA describes a clear geometric contraction in a 5D space. The output FUP plus 4 inputs. When both methods point to the same conclusion, the internal consistency of the analysis becomes very strong. From the VMT viewpoint, the FUP strain decreases steadily from 120 in Y2010 to 80 in Y2025. The cumulative VMT energy curve identifies Y2017 as the clear turning point, where total energy burden begins to decline. The contribution ratios show that carbs and sugar, glucose, weight, and steps all participate in the long-term stress load, with diet representing the largest single contributor. The VMT model confirms that chronic, metabolic and behavioral stress can be reversed through sustained lifestyle changes. The TDA viewpoint shows a parallel pattern. The four-dimensional shape of glucose, diet, weight, and steps is large and unstable before 2014. After from 2015 to 2017, the shape begins to contract. By 2019 through 2025, the point cluster becomes compact and stable. PC1, the dominant geometric direction, is driven by all four stressors, almost equally, confirming that the improvement is systematic, rather than limited to any single factor. The radar chart of 3 years also shows the shrinking polygon, with the largest reduction coming from carbs and sugar. N2 axis, matching the VMT energy ratios. The turning point identified by VMT in Y 2017 is also visible in TDA as the midpoint of major geometric contraction. Before that time, the system shows a widespread and unstable geometry. After that time, the system enters a stable and low stress region. This agreement between cumulative energy reduction and geometric contraction provides strong support that the FUP strain improvement is both structural and long-lasting. In summary, VMT describes the improvement through declining cumulative stress energy, while TDA describes the improvement through contraction of geometric shape. Both methods identify the same turning point, the same long-term trend, and the same dominant role of diet and glucose reduction. Together, they confirm that neuropathy risk reduction in this study is not temporary, but is the result of sustained and coordinated lifestyle improvement over 16 years. Conclusion: peripheral neuropathy is a complex but understandable condition, involving impaired circulation, metabolic injury, nerve degeneration, and reduced sensory processing. Although no single treatment can cure neuropathy for everyone, a combination of lifestyle modification, metabolic control, targeted physical activity, nutritional support, and sensory stimulation can improve symptoms and slow progression. The most successful approaches are those that focus on restoring nerve blood flow, reactivating sensory pathways, correcting biochemical imbalances, and maintaining consistent daily habits that support long-term nerve health. The word treatment usually refers to temporary relief of symptoms. My goal is to eliminate the problem at its root cause and resolve it completely, once and for all. Disclaimer: this content is for educational reference only and not medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be edited or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C. Shu.